picture this clinical reality. You're standing in the OR looking at a diabetic patient who's facing a major limb amputation.
Yeah, it's a grim scenario.
It really is. I mean, you know the statistics, and they are incredibly stark. The 5-year mortality rate after that major amputation is, well, it's greater than 50%.
Which is just staggering when you really think about it.
Right. Compare that directly to our most feared oncologic diagnoses. That mortality rate is worse than colon cancer at 39%.
Wow.
And it's worse than the breast cancer at 23%.
Yeah, it's an unforgiving comparison. We aren't just talking about soft tissue coverage here,
Yeah.
or figuring out how to close a distal third leg defect.
Absolutely not.
We're talking about saving a patient's life and preserving their mobility.
Yeah.
I mean, in this patient population, limb salvage is quite literally life salvage.
Which defines our mission for this deep dive. This is a focused, high-yield clinical briefing on foot and ankle reconstruction.
Exactly. We're bypassing the fluff.
Getting straight to what works in the OR, we're looking at everything from mastering local anatomy and angiosomes to aggressive debridement, flap selection, and the biomechanics of amputation.
Surgeon to surgeon.
Right. So let's build the foundation. Because before you make a single incision, before you even think about raising a flap, you have to understand the foot's exact plumbing.
Yeah, the angiosome concept is your definitive surgical roadmap. Look, you have 6 specific angiosomes in the foot and ankle, and you need to know them cold.
Right. So we've got the anterior tibial artery feeding the anterior ankle, continuing down as the dorsalis pittis to supply the dorsum of the foot.
Exactly. And then you have 2 territories fed by the posterior tibial artery. There's the calcaneal branch feeding the medial and plantar heel, and the medial plantar artery feeding the instep.
And moving laterally, we've got 2 from the peroneal artery, right?
Yeah, the calcaneal branch for the lateral and plantar heel, and the anterior perforating branch for the anterolateral ankle.
Plus the lateral plantar artery feeding the lateral plantar midfoot and the forefoot.
You got it. And recognizing those specific territories, it dictates your entire operative approach. Because here's the key point for the OR.
Okay.
Direct revascularization of an affected angiosome actually increases wound healing by 50%, and it decreases the major amputation risk 4-fold.
Wait, 4-fold? That's a massive difference in outcomes just from targeting the correct vessel.
It's huge.
I always think of the foot's blood supply like a traffic roundabout at a major intersection.
Yeah.
If the main highway, say the anterior tibial, is blocked by a wreck or some heavily calcified plaque, the blood doesn't just stop.
Right. It takes the roundabout.
Exactly. It flows through the arterial anastomoses and basically drives backwards up the road to feed that ischemic tissue.
And the most critical roundabout is right at the least wrong joint. The dorsalis pedis dives deep into the first interspace and connects directly with the lateral plantar artery.
Right. That specific loop determines whether the flow in the anterior or posterior tibial arteries is antegrade or retrograde when you're dealing with proximal occlusive disease.
Yeah. And in real life, I rely heavily on the Doppler ultrasound for mapping this right on the table. But the interpretation is where these cases are won or lost.
Because you place your Doppler probe on the vessel and selectively occlude the collaterals with digital pressure.
Right. You're listening intently to the flow direction. And the acoustic quality, I mean, a crisp, triphasic sound, means excellent elastic flow.
But if it's monophasic?
It's monophasic, you have rigid calcified pipes. And you need your vascular surgery colleagues on the phone immediately.
Yeah, that's a red flag.
Totally. But by mapping those connections dynamically, like that critical juncture deep to the distal Achilles between the peroneal and posterior tibial arteries, you gain absolute confidence.
You know exactly which pedicle will support a local flap without accidentally causing distal ischemia in the toes.
Exactly. You're essentially proving your flap's viability before you even make the skin incision.
But, mapping that perfect arterial loop doesn't mean anything if the patient's foot is structurally collapsing underneath them.
Oh, man, yeah. The biomechanics.
Right, and that's exactly what we see in the diabetic population, where the nervous system itself turns against the anatomy. Neuropathy is the primary driver behind over 80% of diabetic ulcers.
80%.
Yeah, and we often just casually say the elevated blood sugar poisons the nerves, but the actual mechanism is fascinating.
It really is. It comes down to osmotic gradients. The chronically elevated glucose levels lead to high intraneural concentrations of sorbitol.
And sorbitol acts as an osmotic sponge, right?
Exactly, pulling water directly into the Schwann cells. The nerve literally swells up inside its own sheath.
Which sets up a devastating mechanical problem. You have this swollen, Edematous nerve passing through an anatomically rigid, tight space, like the tarsal tunnel.
Yeah, it creates a classic double crush syndrome.
Right. The metabolic damage from the sorbitol is compounded by severe mechanical compression. It drastically accelerates the neuropathy.
And once that protective sensation is gone, the structural integrity of the foot is just living on borrowed time.
Common pitfall alert for the listener right here. Let's talk about the Charcot foot, or neuroarthropathy.
Yeah, this is critical.
It's wild when you look at the numbers because it actually only occurs in maybe 0.1 to 2.5% of diabetics.
Right, but it feels like we see it constantly in the hospital.
Constantly. It presents as this red-hot, swollen foot, and in the ED, it is dangerously misdiagnosed as a bad ankle sprain or cellulitis almost every single time.
Yeah, the misdiagnosis happens because the clinical picture mimics acute infection perfectly. But the underlying etiology, that's where the real debate lies.
Right. I want to push back on the classic teaching here. We were always taught Charcot is purely neurotraumatic.
The old wear and tear theory.
Exactly. The patient loses sensation, they sustain a microfracture, and they just keep walking on an insensitive foot until the bones literally grind themselves to dust.
Right.
But that never fully explained the sheer speed of the collapse. Like, is there a systemic osteopenia factor at play before the trauma even occurs?
Oh, absolutely. The neurotraumatic theory only tells half the story. Newer evidence points heavily to osteopenia triggered by systemic abnormalities in the rank and rank lichen system.
Interesting.
Yeah, this system goes into absolute overdrive. It signals osteoclast to aggressively resorb bone. It's essentially hollowing out the midfoot from the inside out.
Turning the bones into sugar cubes before the patient even takes a bad step.
Exactly. So by the time they sustain a minor ligament injury, the foundation is already completely compromised. And without pain perception to stop them, they just keep walking.
And then you get massive localized synovitis, severe effusion, capsule distension.
The ligaments distort, and they stretch way beyond their yield point. The joint becomes grossly unstable, and then boom, the longitudinal arch simply collapses.
You completely lose the normal calcaneal pitch. The entire biomechanics of the human gait are just destroyed.
Yeah, instead of a smooth heel to midfoot to forefoot transition during the stance phase, the collapsed midfoot takes the entire load.
It creates that massive rocker bottom deformity.
Right. And that focal pressure point acts like a drill against the plantar skin. It leads straight to ulceration, deep space infection, and eventual gangrene.
And once that pathology is recognized, whether it's a Charcot ulcer or a standard neuropathic wound, you are in the OR. This is the arena where limb salvage cases succeed or fail.
The evaluation has to be absolutely ruthless.
So let's hit some vital diagnostic pearls. Say you're exploring the wound on the table. If you take a sterile metal probe, and you can feel a hard, gritty bone base at the bottom of that ulcer.
There was an 85% chance of underlying osteomyelitis just from that tactile feedback.
Right, it gives you your answer. And the size of the defect tells a similar story. Any diabetic ulcer measuring over 2 square centimeters carries a 90% chance of underlying osteo.
Regardless of what your probe tells you or what the surface looks like.
90%. That's a clinical reality we have to respect.
Huh.
And another one, do not rely entirely on plain radiographs early in the presentation.
Oh, definitely not. Plain x-rays lag behind the clinical appearance of the bone destruction by up to 3 weeks.
Right. If your clinical suspicion for osteo is high, you need an MRI to define the true extent of the marrow edema.
Which brings us to the core procedure of limb salvage. Debridement.
Yeah.
I mean, it is arguably the single most underperformed and underappreciated procedure in all of foot and ankle surgery.
It really is chronically underperformed because we underestimate the enemy. We are dealing with structured biofilm in over 90% of these chronic wounds.
It's not just a superficial layer of slime you can wipe away with a wet lap sponge.
No, the microscopic architecture of biofilm penetrates incredibly deep. It tracks right along the peривascular planes of the arterioles that feed the wound bed.
It can infiltrate up to 4 millimeters deep into what looks like relatively normal tissue. Look, if you're just skimming the surface...
You're leaving the root system of the infection completely intact.
Exactly.
I'll admit, early in my career, I really struggled with closure anxiety. You know what I mean?
Oh, everyone does.
You're standing there with a curette and a scalpel, staring at a massive hole, and you hesitate to debride aggressively because you're terrified of making the defect even larger.
Right, you start worrying about how you're going to get soft tissue coverage over this crater you're making.
So how do we train surgeons to overcome that hesitation?
By reinforcing one absolute unforgiving truth, leaving dead, fibrotic, or infected tissue behind, guarantees total failure.
Right.
It guarantees progressive necrosis, hardware infection, flap loss, and eventual amputation. You have to debride relentlessly until you hit healthy bleeding tissue.
Use tissue colors as your operative guide.
Exactly. You want to see vibrant red muscle that twitches, bright yellow lobular fat, and glistening white bone or tendon. Anything gray, dusky, fibrotic, or non-bleeding, it comes out immediately.
A phenomenal clinical tip for ensuring thoroughness is using methylene blue dye.
Oh, I love this technique.
Right. Before you make a single cut, you paint the base of the wound with blue dye. Inject it with a blunt angiocatheter into any undermined edges or sinus tracts.
And then you debride until every single trace of blue is completely gone.
It visually forces you to be thorough and takes the guesswork out of the margins.
And once you establish a pristine, surgically clean bed, you finally have a baseline to measure progress. Normal, healthy wound healing progresses at a rate of a 10 to 15% decrease in total wound area per week.
Okay, so if your wound is contracting slower than that,
You still have a problem. You either have retained biofilm, terrible biomechanics, or unrecognized ischemia.
right. Now, that closure anxiety we mentioned earlier, it's a real psychological hurdle, but modern reconstructive tools have completely shifted the paradigm.
They really have. We aren't jumping straight to complex 12-hour free flaps for every massive defect anymore.
Right. The reconstructive ladder has evolved into a reconstructive elevator. We skip steps when appropriate, but we also rely heavily on advanced modalities to simplify our coverage.
Today, more than 85% of complex foot and ankle wounds can be closed with simpler, highly reliable techniques.
Okay, let's unpack this shift. We're talking about utilizing negative pressure wound therapy, advanced dermal regeneration templates, and split-thickness skin grafts.
Right, only 10 to 15% of these patients actually require complex regional or free flaps.
There is a real temptation to go straight to heroic microsurgery, but the modern approach is about building a foundation first.
Exactly. You can build an incredibly robust, vascularized granulating bed over exposed tendon or even decorticated bone by combining negative pressure therapy with bilayer dermal templates.
You give the body a scaffold to generate neodermis.
And once that vascularized bed fully incorporates and turns a healthy peach color, you just bring the patient back to the OR and apply a simple skin graft.
Here is a massive skin grafting pearl for the listener. For plantar surface defects, your standard phi skin graft will not hold up to the sheer forces of walking.
It'll break down immediately.
Right. Your ideal donor site is the thick, glabrous skin from the plantar instep of the foot itself. It resists shear and pressure beautifully. You harvest it with a dermatome set at 31 thousandths of an inch.
But harvesting that thick graft leaves a painful donor site on the instep.
It does.
So to protect that donor site and ensure it heals rapidly, you harvest a much thinner standard graft around 15 1/1000ths of an inch from the anterior thigh and use it to cover the instep donor site.
It's a highly effective trade-off.
Totally.
But here's where the rubber meets the road in real life. You can execute the most beautiful, perfectly contoured, glabrous skin graft in the world. But if the biomechanics of the foot are wrong...
That graft will ulcerate again in a month.
Exactly. A tight Achilles tendon is the main culprit for the vast majority of forefoot plantar ulcers.
It acts like a rigid tether. A contracted Achilles complex physically prevents adequate ankle dorsiflexion during the stance phase of gait.
Because the ankle can't bend upward, the entire propulsive force of the body is driven violently downward into the metatarsal heads.
And this is where a brutally simple intervention changes the entire trajectory of the patient's life.
Performing a percutaneous Achilles release or a formal gastrocnemius recession, it drops that forefoot pressure instantly.
The data is just staggering here. Addressing that equinus contracture literally cuts ulcer recurrence by 50% at 2 years.
50%. Just from a tendon release?
Right. And to determine which release to perform, you rely on the silver skeel test right there on the OR table.
Okay, walk us through that.
You assess ankle dorsiflexion with the knee fully extended, and then again with the knee flexed to 90 degrees. If they can't dorsiflex past neutral with the knee straight, but they suddenly can when the knee is bent, the gastrocnemius muscle alone is the tight restrictive element.
So you perform a gastric recession.
Exactly.
But if they can't dorsiflex to neutral either way, knee straight or knee bent, then both the gastrocnemius and the soleus muscles are contracted.
Right. In that scenario, you need to perform a percutaneous lengthening of the Achilles tendon itself to get the release.
And you must address those biomechanics early, often during the very first debridement.
Absolutely. But let's look at the threshold for escalating our coverage. When simple measures like dermal matrices and negative pressure fail to granulate over the defect, you have to move up the reconstructive ladder.
Right. The clinical threshold for pulling the trigger on a flap is pretty clear. You escalate to a flap when you're staring at an exposed joint capsule, an exposed tendon stripped of its peritoneum, or exposed cortical bone that completely fails to generate granulation tissue.
You need to bring in healthy, well-vascularized bulk.
And the foot and ankle territory is uniquely unforgiving when it comes to local options. Let's break down the local and pedicled flaps. For plantar defects, particularly around the heel and midfoot, the medial plantar flap is your absolute workhorse.
Oh, it's brilliant because it provides sensate, highly durable, glabrous tissue that is actually designed to bear weight.
Yeah, you can base it on either the superficial or deep branch of the medial plantar artery, but in real life, harvesting it on the superficial branch is far superior.
Why is that?
Because it preserves the deep, dominant inflow to the rest of the plantar foot.
Ah, right. Now, for defects of the posterior heel and the Achilles region, their retrograde sural nerve flap is highly versatile. It provides excellent coverage without sacrificing a major axial vessel.
But the venous drainage is the Achilles heel of this flap.
Venous congestion is a nightmare with the sural flap.
Yeah. The lesser saphenous vein contains valves, and relying on retrograde flow through collateral bypasses around those valves, it can be highly unpredictable.
So the rule to minimize congestion is to leave a wide 3-centimeter tissue buffer of subcutaneous fat around the pedicle during harvest.
Right. Do not try to meticulously skeletonize the pedicle, or you will completely destroy the fragile venous plexus surrounding it.
Good tip. Now, when we look at local muscle flaps in the lower extremity, the options are severely limited.
Yeah, the lower leg muscles are predominantly classified as type 4 muscles based on their vascular anatomy.
Meaning they rely on multiple, small, segmental arterial pedicles rather than a single dominant supply.
I've always found local muscle flaps in the lower leg to be incredibly frustrating. Because of that type 4 anatomy, you can only safely transfer a tiny portion of the muscle without performing a complex delay procedure.
And let's be honest about the extensor digitorum brevis, the EDB flap in the foot.
Oh, man.
You dissect it out thinking you have a great local option, but it has disappointingly little bulk.
Right. It works well to plug a small defect in the sinus tarsi, but do not expect it to fill a massive lateral ankle hole.
Which forces us to confront microsurgery realities. When you run out of local and pedicled options, you look at free tissue transfer.
But we have to acknowledge the hard data. Free flaps performed in the foot and ankle carry the absolute highest failure rate of any anatomic location in the human body.
It's a tough neighborhood.
I want to dig into the reality of that failure rate. We know operating on diabetics means dealing with heavily calcified vessels. I mean, you practically need a specialized hardened microneedle just to drive through the arterial wall without tearing the intima.
Yeah, it's like sewing eggshells.
Exactly. But my biggest headache in these cases is the zone of injury. It's so easy to trick yourself into thinking a recipient vessel looks healthy, only to realize your anastomosis is failing because you're still inside the blast radius of the trauma.
The zone of injury extends microscopically far beyond what you can actually see with the naked eye. The endothelial lining of the vessels is damaged, it's highly thrombogenic, and it's prone to severe spasm.
Right. The primary pitfall is performing the anastomosis immediately adjacent to the traumatized tissue.
You have to ruthlessly dissect, well, proximal, or occasionally distal, to the wound bed until you find absolutely pristine, unscarred vessels.
And whenever geometrically possible, perform your arterial anastomosis end to side. You want to preserve whatever main axial flow is left going down to the foot while siphoning off flow for your flap.
Now, if the microvascular salvage fails, or if the initial tissue destruction is simply too massive to reconstruct, we have to talk about amputation truths.
We really need to stop viewing amputation as a failure and start treating it as a definitive reconstructive procedure designed to optimize function.
Precisely. If you're performing a local forefoot or ray amputation, the cardinal rule is to maximize toe length.
Keep the base of the proximal phalanx if you possibly can.
Right, because it acts as a critical mechanical spacer in the shoe and prevents the adjacent toes from drifting into severe, painful angular deformities.
And when you move proximal to a midfoot amputation, like a classic Lisfranc amputation where all the metatarsals are removed, Biomechanics become your greatest enemy if you don't balance the foot.
Yeah, by removing the forefoot, you completely lose the insertion points of the major ankle dorsiflexors.
So if you just close the skin over a Lisfranc amputation and send them to recovery, the massive posterior calf muscles will overpower the foot.
They'll pull it into a severe, rigid equinovarus deformity.
And they'll end up walking directly on the distal tip of the bony stump, which guarantees ulceration and a higher level amputation.
So to prevent that cascade, you have to actively rebalance the tendons during the amputation. You split the anterior tibial tendon and securely insert it directly into the cuboid bone.
You combine that transfer with a generous Achilles tendon lengthening.
Exactly. That specific combination balances the mechanical forces, keeping the stump plantigrade and allowing the patient to actually walk in a specialized, custom-molded shoe.
It all comes back to the overarching goal, saving the patient's mobility and preventing that lethal downward spiral.
Let's bring all these technical details together. The core pillars of foot and ankle reconstruction remain constant regardless of the defect size.
First, definitively restore the blood flow directly to the affected angiosome.
Second, debride aggressively until you hit healthy bleeding tissue. Do not let closure anxiety compromise your margins.
Third, secure biomechanical stability through tendon balancing or joint offloading.
Perfect.
We covered a tremendous amount of ground today, from navigating the Lisfranc arterial loop and overcoming the depth of perivascular biofilm to the 3-centimeter buffer rule on a Sherrill flap.
It's been a great deep dive.
But I want to leave you with a final thought to consider before your next diabetic foot consult. We know that a simple percutaneous Achilles lengthening combined with aggressive debridement can literally halve the rate of ulcer recurrence.
Right.
And we know that preventing that single recurrence stops a brutal cascade that ultimately leads to a 50% 5-year mortality rate.
It's sobering.
It is. So given the sheer weight of those numbers, are we as a surgical field fundamentally undertreating biomechanics early in the disease process? Could a 10-minute percutaneous release in the OR save more lives and limbs than a heroic 12-hour free flap? Think about that the next time you're evaluating a plantar ulcer.